everyone, and welcome to another episode of Public Health Musings. I'm your host, Dr. Caroline Kingori, a faculty at Ohio University. I'm so excited about today's guest, who happens to be a young professional, but she's also my friend. But before we jump to the interview, I want to ask all the listeners to remember to subscribe to the podcast on the audio platforms where you listen to. And if you're watching this, also ensure that you subscribe to this podcast on YouTube. So I have a treat for you today. I'm so happy. My guest is Dr. Margaret Waru Gichane, and she's an assistant professor and social and behavioral scientist at Advancing New Standards in Reproductive Health that's based at the University of California, San Francisco. Her research is dedicated to identifying and addressing the structural and social factors that produce disparities in sexual and reproductive health outcomes here in the US and also in sub-Saharan Africa. In her work, she uses many methods that are participatory, but also applied qualitative methods, which includes, interviews, to look at sexual and reproductive health services, adolescent sexual behavior, as well as HIV prevention and treatment interventions. So she holds a BS in Human Development from Cornell University, an MSPH and PhD in Health Behavior from Gillings School of Public Health from the University of North Carolina at Chapel Hill. Welcome to the show, Dr. Gichane. I'm so glad to host you.
So excited to be here today.
Awesome. So this is something I ask of all my guests. You know, we always want to know what got you to the place you are. How did you get to this point? What motivated you to want to now be a professor, to be interested in public health? You're out there in the sunny state of California. Tell us your journey.
Like many child of immigrants or an immigrant myself, I think I wanted to be a doctor first, but somehow ended in public health. But I think where my story really starts is, so I worked at a McDonald's when I was in high school. So I lived in a small town in upstate New York that was kind of rural. And while I worked there, slowly, a few of my peers started becoming pregnant, and we'd sort of talk about it while we're working there. And, we lived in the kind of place where we had access to condoms, contraception. There was a Planned Parenthood. There was condoms in the nurse's office at school. There were really ways to prevent pregnancy. But, when we were talking about it, I came to learn that it was more like, I really want to be closer to my boyfriend. If I have his child, we'll have a closer union. Someone else talked a little bit about, I really want to be, a baby who will love me. I think, and then also when I think more about the town we lived in, there was no other jobs. If you didn't have a degree, you either worked in some sort of customer service, we had McDonald's, Walmart, those other kind of cities. So there really wasn't many opportunities where we were. So I think when I started thinking about it, I was like, okay, there's something deeper going on here. I think we all know how to prevent pregnancy, but there's something else that could be leading to this. So, I didn't know that was called public health. I thought maybe that's medicine. So I went off to university, and one really bad grade in organic chemistry and crying and realizing maybe this isn't the field for me, followed by the next semester where I took an intro to global health course that I was like, oh, okay, maybe there are words for what it is that I'm learning here. And so that just really inspired me to, really be interested in adolescent health, in, pregnancy prevention programs, learn more about HIV. And so sort of from there, I had a research assistant position, and then I went on to get a master's and PhD because I knew some of these questions that I had about sort of what is happening just around us were really important when we talk about sexual health.
Wow, that's awesome. And when you think about how you came into this to where you are today, it looks like your journey in reproductive and sexual health began way back when. Not just public health. I mean, looking at all these pregnancy outcomes in young people. And in the introduction, I talked about how your focus in public health is looking at those structural and social factors as well as disparities. So I wanted to talk a little bit about that. So we'll get to the really nitty gritty. How would you describe sexual and reproductive health? What is that field?
To me, it means that I'm really interested in making sure that people have the sexual and reproductive lives that they want. And so this means support you if you choose to abstain, if you're choosing to have multiple sexual partners, if in all the different ways that you want to be a sexual being, or your choice to have or not have a pregnancy. I think I want to make sure that all those options are available to you. And so to me, it's not really the absence of disease, but really an outlook on just wholeness, wellness, and choice.
Awesome. And so with that background, then you also look at now other factors that could potentially impact that freedom, right? Mm-hmm. That opportunity to make those choices and things of that nature. And you break this down in form of structural and social factors. So for those people who don't know what that means, could you tell us what are these structural factors and social factors, and how do they influence the outcomes in sexual and reproductive health?
Yeah, so when I think a little bit about sort of those structural factors, I think, what are the things that can stand in the way for you to make the decisions that you want? And so I think I like to think of sort of in an ecological way, sort of, okay, what is it? On one level, what are the economic resources that you have or that your family has? So this is, are you able to get an education? Do you have employment? Do your parents have employment? And because we know that these sort of resources within your household really impact, whether you have health insurance, whether you have a clinic that's close to you, whether you can get to the clinic. And then there's factors sort of that are happening around you. When I think of my town, saying, there's few jobs that were available. And so, how does that, when you look towards your future and you don't see that around you, that just tells you something about what's available. And also sort of the clinics, the health centers, what are those that are available? And then even, I have colleagues who study sort of what is the political environment, in your state. Is this a state that allows access to, do adolescents need consent from their parents to get contraception, to get an abortion, to get, other sexual and reproductive health care that they need? And so that's how I think about the structural. For the social, I think, there's a lot of things, there's stigma around different sexual health care services, for HIV prevention. How do people talk about things like pre-exposure prophylaxis or PrEP, which is an HIV prevention tool? How do they talk about those who are living with HIV, and are they stigmatized? There's the relationships you have with your partners. Is there violence? Is there cohesion? Are you close to the people around you? And so I think there's, what's really exciting in studying this field is there's so many things that are around us and that are really relevant to us in our personal lives, that can impact your health, just beyond just that, the medication that's available or the clinical services that are there for you.
And I'm so glad you explained that, because we tend to reduce sexual and reproductive health to just youth are engaging in, promiscuity, if you will, mm-hmm. or the youth getting distracted. And there's so much more that we don't understand as a society. And, you brought out the issue of structural barriers, thinking about clinics. We know there's a concept about youth-friendly clinics. We know that to be able to have this youth take advantage of these services in the clinics, we have to think about things like the hours, right? How long are these clinics open? But also the people in the clinics, are they trained well enough to meet the needs of youth? We have healthcare providers who, young people will go there and try and talk to them about contraceptives, and what they're told is, you need to focus on your education. This is not the time to think about these things. But they are thinking about those things. We know that the developmental stage brings with it a lot of questions and confusion and challenges. And I think it's important for us to embrace this sexual and reproductive health, especially from a young people perspective, with a different lens. And I'm glad you focus on those social and structural factors. So you focus also on global health issues, right? So could you tell us a little bit about the global disparities right now impacting this targeted reproductive and sexual health outcomes?
In sort of the HIV prevention world, we see that, young women, girls and young women ages 15 to 24 have really been the focus of a lot of HIV prevention efforts, because they have a higher HIV incidence compared to boys in their same age group. And if you look across sub-Saharan Africa, in some places there's parity, but other places it's 3 times, 4 times as high as HIV incidence compared to young men. And so that's really alarming. And so I've, done some research. So what is happening there? There's a big body of work about, sort of who the partners are of this age group. Some young women have older partners who might be, not in their same age group, but in an older one, where sort of the HIV incidence increases for young men. There's also, again, these social and structural factors I'm talking about. Some women living in poverty might have some transactional relationships, which might increase their HIV risk as well. And so I think we also see in some places too, with pregnancies, higher rates of unintended pregnancies about some of the younger women as well. And again, it all falls into that same social and structural climate.
Right. And going back to HIV and, again, looking at youth, which is who we're going to focus on today. I know you've worked on a lot of research on different aspects of those social and structural factors. But I looked at some of your work and I was really impressed by this one paper that, looks at HIV, especially in Southern African region. And the paper examined the feasibility of integrating the Peaverine, is that how you say it?
The Peaverine.
The Peaverine, yes. The Peaverine
Yes.
ring as an HIV prevention intervention into women's lives. So what we know, basic intervention strategies, condom use and pre-exposure prophylaxis and PEP post-exposure. And now they're coming out with this different other types of interventions that give women some sort of empowerment. So I know there's that ring. I know there's some creams that are out there too. So tell us more about this ring and what you found and the uptake of that ring in the population that you worked with.
Yeah, thank you. This was a paper I was really excited about because what we found sort of in pre-exposure prophylaxis or PrEP, the main mode that PrEP has been delivered up until the last few years was as a pill. And we found that this was just not working for certain populations. So while there's been high uptake of PrEP among men who have sex with men in various high-income countries and in some low and middle-income countries, when PrEP was introduced to young women, it just wasn't working. I think adhering to a daily pill is difficult for anyone, but especially, a young woman who's at home, there's questions, what is this that you have? You might not see your risk as that high. If you're only having sex once or twice a month, they're like, why would I take a pill? I think, sometimes as researchers, we can get far removed from what is happening in people's lives. And so the Peaverine vaginal ring is it contains an antiretroviral, similar to the ones we know from PrEP, so called the Peaverine. And so it's a small plastic ring about this big, and you insert it inside of your vagina, and it lasts you can wear it continuously for about, I think about 3 to 4 weeks. And so you wear it continuously. And the ring slowly releases the antiretroviral throughout your body, which can helps prevent HIV. And so what we were studying was sort of understanding, okay, now this has mostly been tested in clinical settings. What happens now when we give women 3 rings to take home and sort of see how do they deal with it in their home environment? Do they have somewhere to dispose of it? Do they feel comfortable changing the ring in their house? Are there people around them asking, what is this? Or even, for some, are there pests in the house? It is a medical product, and you want to make sure that you're able to dispose of it in the way you want. And so I worked with a team from RTI and multiple partners in Zimbabwe, South Africa. And we were interested in we asked young women to sort of draw a map of their home and tell me, okay, where do I put on the ring? Where do I dispose the ring? Do I have privacy? Can I put it on, take it off, and just feel really comfortable with that? And so I was part of the data analysis phase, just looking at these images, listening to their interviews, and just sort of really understanding what that concept was. And so, it seemed like, they were like, women felt, okay, I feel comfortable using this ring at home. I think I have some concerns about my children getting into the rings. One woman talked about her kids putting the rings on their wrist and playing with it. So, to be expected, right? And so they talked a little bit about the boundaries they had set, who they were comfortable sharing with. And also that there were concerns sort of about hygiene as well. If you have a shared bathroom, showering area, feeling less comfortable, but they thought to themselves, okay, maybe I can shower at this time of the day when there's no one around. So it seemed like they had established strategies for themselves to make this feasible, but that, when implementing this, maybe these are some questions that clinicians can ask about being safe. Do you have somewhere to store it? Do you have somewhere to dispose of it? So that they can create a plan together of, is this a strategy that will work for you?
Very interesting. Thinking about already having that stigma, just being HIV positive and or not. People, we're thinking about pre-exposure. It's people who are not positive, but are engaging in risky sexual behavior and navigating those challenges that they have to protect the fact that they're taking this medication so that others don't know that they're taking that medication. And I'm wondering, Do you know if at any point there's a way that there was some sort of counseling, for the whole family, or maybe for their partners, sexual partners, husbands, what have you, significant others, to help with that uptake and acceptance of that type of intervention?
I wasn't part of that part of the study, but I know that has been really a focus of, they call this a female-controlled method, but there's some women talked about taking it out during sex because they're like, oh, what if he feels it during sex, or if it falls out? And so there was definitely some concern about that. And so I know there are interventions in place for sort of community sensitization, and some with partners, and I think there are potentially some tensions, but I wasn't part of that phase. But I know, I know that is definitely a big part of moving this work forward, is making sure that it fits into not just her life, right, but all the partners she may have.
So continuing with the HIV discussion, I know that something else you've also looked at is the use of alcohol, and that is such a big issue, I know, in the Southern African region, but also in many other cultures. And we know that people may use alcohol as a coping mechanism, but we know that it can interfere with, the immunity of individuals, and even just making informed decisions, right? So what did you discover in your research with HIV positive women in South Africa, and that relationship with alcohol use and them, protecting themselves from HIV?
Yeah. So, South Africa in particular has been really a focus for research on alcohol and HIV. It has one of the highest per capita alcohol consumption. There's a long history of sort of how that came to be, always thinking about the social and structural, but for women in particular, there hasn't been as much of a focus on alcohol consumption among women. And I was working on a project just better understanding, how we can manage alcohol, what kind of tools women need to sort of manage their alcohol use, which will then in turn help them be consistent with their medication. They're taking their HIV medication. And so sort of the things we found, a behavioral intervention was given to women, and we found that, they learned strategies. I think alcohol consumption remained high, it's real, but it was still reduced, which I think is important. I think, if we take a harm reduction approach, it's not, I think completely eliminating alcohol might not be feasible or desired for a lot of different people. And so once learning strategies for, safer alcohol, like what does it mean to maybe drink at home rather than in a bar that could be unsafe and make you at risk for violence? What does it mean to drink alcohol, but also drink water at the same time to help manage your use? Drink only around friends, to make sure you have a supportive environment. And so we were interested. So we learned a lot about some of these strategies that women were employing, that they came up with themselves, as well as from the intervention. And that, having some of these tools really made them feel like they were better in control of their alcohol use, which was really positive. And so it's just exciting to see sort of how we can, integrate the different layers of things that can increase risk, just violence, alcohol use, and sort of HIV as well.
I'm glad we're going through some of those social, cultural, structural factors that really impact, again, the larger sexual and reproductive health, but particularly HIV prevention, knowing the incidence and the prevalence rates are really high in the Southern African region. And, we'll turn a corner here because one of the things that you brought up with regard to risk factors for, HIV in youth is transactional sex. And we know in many of the impoverished communities, transactional sex is common as a means of livelihood. We know it's a risk factor for HIV infection. And so I wanted to talk a little bit about the papers and the work that you've done in that area. So you have a couple of projects that looked at socioeconomic and individual and relationship predictors or factors of transactional sex in Malawi. So tell us a little bit more about that project. What are these socioeconomic factors? What are those individual factors, beliefs, attitudes, and as well as relationship factors that can predict this transactional sex and put them at a greater risk of HIV infection?
I'll start by first defining transactional sex, because I know it's a word we sort of throw around. But so these are relationships where there is an implicit assumption that sex will be traded for material or monetary goods. And so I like to think, I think a lot of relationships have a transactional nature to them. I learned about this while I was working on this project, this transactional sex framework that talks about, there's transactional sex for love and material and sort of how people show romance in a relationship. There's a type of transactional sex for material goods. So this is luxury items like the latest perfume or whatever is considered, something desirable in your community. And then there's transactional sex for basic needs. So this is someone who might be in a situation where this is the only way they can get food to eat, maybe, or pay a school fee or pay something else that they really need. And so I just sort of give that context to understand that, there are transactional relationships sort of across the world that might just look really differently. And so for this project, I was really interested in sort of breaking down what are the dimensions of those economic factors. Like you were saying, that, people in impoverished communities might be at higher risk for engaging in transactional relationships, and sort of understanding what are these factors? Like, it's not, because not everyone who is in such a situation might be engaging in transactional sex. What could, so I was interested in sort of understanding, is it food insecurity? Is it education level? Because all of these different factors would need a different type of intervention to help maybe either reduce transactional sex or make it safer. At least people, are using condoms, partners, being with partners that, they deem to be safe. And so I was really interested in understanding those different dimensions. And so some of the things we found were those in unstable housing. And so not having a place where you sleep consistently, food insecurity, which I think has been found in other studies. And I think something that was particularly interesting was young women who were divorced or widowed. And so I don't think you always think of, especially younger women, being divorced in the sort of 15 to 24-year-old age group. And so I think that took, understanding maybe what could that mean for this age group. I think maybe these weren't it wasn't maybe a formal marriage recognized legally, or maybe in some communities, but it means that it was a really serious relationship that was broken apart, which could mean, you previously went from having consistent support to inconsistent support. So this could be a group that we should especially think about when creating interventions. And the other paper that was an offshoot. Now, who are the partners? Who are the transactional partners? And so, you know, we found some were 5 to 10 years older. We found that one of the characteristics is these were relationships where there was violence. So this was a partner that they said, maybe this is not someone I would fear being abandoned or physical harm if we considered HIV testing together. So that tells you something about the relationship dynamics there, that maybe this isn't the safest relationship for them, for some young women, and also for some that they were also in concurrent relationships. And so maybe there's another partner in the picture, so which tells you that there's a potential that the risk for other STIs, HIV could be higher if they're in two relationships at the same time. So I think together, all these tell you that transactional sex is common in this age group, and that these, you know, if we're trying to, you know, target interventions, these are sort of the things that we should consider.
So looking at those factors, it seems that there's so much, you know, weighing and against, and so many risk factors to consider, especially for youth, right, and young adults, and thinking about all the other things that also they have to contend with. And then we add the complication of HIV prevention and other sexually transmitted infections. And, you know, this is definitely a continuous battle in trying to minimize the risk in this target group. And so to help address transactional sex, one strategy has been to use cash transfers, right? That it can improve economic empowerment. So, I mean, I've seen a lot of literature out there on the pros and cons of cash transfers. In your work, what have you found? Have you found this as an effective strategy in reducing transactional sex among young women in sub-Saharan Africa?
Thank you for bringing that up. I think, you know, have sort of a complicated history of, you know, I think some studies have shown they work really well. Other studies have shown they aren't effective. In my work, what I've found is that it's complicated. You know, when I talked about sort of those different types of transactional relationships, I think cash transfers can potentially reduce sort of that basic needs category. So I conducted this, you know, was part of a study on understanding cash transfers and transactional sex in Tanzania. And, you know, the young women said the ones who the cash transfers really impacted is they were saying, like, I didn't have food to eat. I was in this transactional relationship, and having, you know, sort of a cash flow. When I had a situation where I didn't have anything else, I at least had that cash. And I think that's really important in, you know, places where there's few means of employment, you know, if you don't complete your school. And so I think that's where the cash transfers can be most effective. And so I think, you know, they have to be paired with other sort of programs. It's not just the cash. It's, you know, is there life skills training? Is there potentially access to education or startup funds to start a business or something just to sort of round it out? So, you know, because the cash always ends, right? That these are programs that aren't going to be forever. And so are there other resources that are available to sort of ensure that the benefits of cash remain for a longer time?
So then how do you sustain such an intervention? What have you seen in the literature?
Yeah, I think that's a good question. And I think a lot of smart people are trying to figure that out right now. Hope to be one of them. But I think, so there's another model of cash transfers is through government programs. And so a lot of, various governments have sort of a social grant program. And so this could be if you have a child, this could be if there's someone in your home with a disability. If you meet certain economic thresholds. And so that's sort of a long-standing cash transfer program. And so I think there's researchers at UNICEF studying how government cash transfer programs can be paired now with other social programs to help to sustain behavior change among young people. And so they just recently, there's a program called Ujana Salama, and they just found, I think, that the program reduced sexual violence. And so I think, it's really exciting that how can we use programs that the government has already approved that are sustainable and sort of add something onto them that potentially, if found effective, the government could easily integrate. So I'm really interested in how understanding these different models that can be developed, evaluated, and hopefully sustained over a long period of time.
And I'm pretty excited about the kind of work you do because I find it really practical. It's not a matter of, these young people are they're being promiscuous, or they're being careless. Some of the recommendations we've seen in literature is they just need to stop having sex with multiple partners. It's not that, easy. It's a very complicated issue. And people have not for a long time understood just the complexity of HIV itself. Yeah. Not just as a disease, but as a social and economic problem. And the decisions that people have to make to eat, to feed their family, to have some sort of economic support. They engage in this transactional sex and engage in other behaviors that really put them at risk for HIV infection. And this is why I wanted to have this discussion so that we can show that HIV is not just a simple health issue that can be addressed by, just give them PrEP, And if they're having too much sex or they're putting themselves at risk, PrEP will sort that out. Okay, they're HIV positive. Sure, we have antiretroviral medication. So we don't have to worry about HIV anymore. But no, we have to continue worrying about HIV because of those linkages to these structural and social factors that you've, helped explain. And so we can't say, we're done with HIV. It's no longer an issue. It is still an issue because of the complexity and, the interrelationships it has with other issues. So with all that you've done, you did talk about some policy work that's out there. What do you think are the policy implications of the work that you've been engaged in? I mean, we're talking about cash transfers, we're talking about that ring, this has some expensive strategies. So what are the policy implications for that?
That's a great question and probably one that I should ask myself more often. But, I think, as we were saying with sort of the cash transfer, I think we need to understand or develop policies that sort of see that prioritize adolescence. What I think in cash transfer programs, often the money might be going to the head of household, right? And unless the adolescent themselves is a head of household, that means that potentially the support might not be going to them. And so we need to sort of understand the fullness of adolescence as, individuals in our society, like youth are the future. There's, we're talking about the youth bulge in especially in the population in Africa, especially. And so I think we need to, what are the policies that we can put in place to sort of help with those socioeconomic factors? I think things like, with sexual health, we need to think more broadly about what policies could help with ensuring universal educational access. What is it for food security programs? Those things like that can have a trickle down for sexual and reproductive health. I know right now there's a lot of efforts in Eastern Africa. There's youth bills on making sure that there is, comprehensive sexual health education. We want this in schools. We want this in community for those who aren't in school. And so I think it's ensuring that there's access to as much information, and that is required by law. I think that's the most important thing. It's just not something we talk about. It's something that is widespread and mandatory.
Yeah. And we can no longer, dig our heads in the sand and keep maintaining those old time thoughts about, if we talk, if we introduce our youth to sexual reproductive health and comprehensive sex education, that's going to increase their sexual activity, and which is contrary. We have, there's evidence to show that abstinence-only programs do not work. Providing information helps people make informed decisions. It doesn't equal to youth engaging in more sexual behavior. And, that theory has been debunked. And so I applaud, East Africa and all the other places trying to implement this comprehensive sexual education programs. And so, you've done all this work, you've moved across to the other side of the US, you're in California, you've done work in multiple countries in Africa. So just wanted to know, what is your most memorable moment in your work or life to date? When you look at your journey, I know there's a lot, but maybe one or two memorable moments.
Gosh, I think it's always been the moments that mean the most to me are when I've gotten to engage in sort of more participatory processes. And so I didn't talk about this, so much in my intro, but one of the things that I'm really interested in, sort of the intersection of disability and reproductive health. And so a few years ago, I did a project in South Africa, understanding sort of the maternity and maternal health care experiences of deaf women. And that was a project that was, our staff was, some of our staff were deaf, we had interpreters, and just really how can you create an inclusive research environment? How do you ensure sort of that the questions that you're asking really impact the lives of those you're working with? And so I had really inspirational mentors at the University of Cape Town who had long-standing partnerships with community organizations that supported deaf communities in Cape Town. And so that was one of the projects where, we did outreach during deaf church services in different schools. And that was an opportunity where I was like, okay, this, and this, research we're doing was for a tool, was used as advocacy for ensuring that interpreters were available in health clinics for every medical appointment, not just and on demand, especially during emergency care, So, young women talked about, I didn't have an interpreter during labor and delivery, so I didn't know what was happening to my baby, And I think that we don't always talk about language access and disability and reproductive health conversations. And so I think that, was an important project for me, for advocacy, for inclusion, and for really doing work that is really implementable in a quicker scale. So that, I think, was an exciting project for me.
Wow, that's good to know that you did that. We don't talk about that often. And so I hope that you do get an opportunity to do that and bring me on. We are already collaborating on something right now. But that would be really interesting to understand those challenges, because there are multiple challenges because of what is considered a disability for them. But I just want to say thank you so much for joining me today. And if people wanted to, get in touch with you, how can they do that?
Yeah, if you want to, you can email me at waru.gichane@ucsf.edu. Happy to connect with you, or on Twitter. I'm not that interesting on Twitter, at WaruG. Thank you so much.
Awesome. So thank you to everyone who has tuned in, whether it's audio or on YouTube. And, I'm looking forward to having you back on another episode of Public Health Musings. I don't know about you, but every day I just find public health extremely amazing. And I just discover new things every single moment.
Definitely. Thank you so much for having me on.
Awesome. So we'll talk to you again. Have a good one, everyone.
Bye.